Greetings, everyone. Welcome to the 176th session of the online Optom Learning Series, OOLS. And for today's session, we have with us Dr. Sathi Maiti. Dr. Maiti is an ocular surface disease clinical research fellow at the Perelman Eye Institute and primary eye care optometrist in Seattle, Washington. She graduated from the UC Berkeley School of Optometry in 2014. She is a sub-investigator of a number of clinical trials which are related to dry eye and ocular surface diseases. She is also a part of the editorial boards of Eyes on Eye Care. I think this has gained a lot of popularity with the amount of efforts Eyes on Eye Care have put in numerous ways, in numerous subspecialties as well, right? In dry eye, in glaucoma, and everything in primary care optometry. She is also on the editorial board of the Journal of Dry Eye and Ocular Surface Diseases, and she recently was named as one of the Vision Monday's most influential women in optical for 2021. She is member of numerous organizations, takes active participation in training, teaching, as well as educating optometrists and optometry students across the US. And on social media. I think that's something very interesting where she shares about eyes and everything about eye care on her Instagram page, which is Dr.Maiti's Eyeball and Stuff. So I think if you are interested to know more about what work she does, education and all of that, you can follow her on her social media. And today, Dr. Maiti is going to talk to us about IPL, intense pulse light therapy, and how do we use this for treatment of dry eye, and will take us to the best practices and the updates on the same. So welcome, ma'am, onto our platform. And, let me just leave the screen time to you.
Sure. Yes, thank you so much. I'm really honored that you asked me to speak to your audience. So this is a talk that I actually originally gave for an Eyes on Eye Care event called Eyes on 2022. So that's why it has that logo there. So yes, I practice in Seattle and primarily work with dry eye and dry eye related clinical trials. So I do have a few financial disclosures, a few more actually from when this talk was made, which includes working on some clinical trials and getting funding from Luminous, Alcon, Novartis, and Tarsus. And I did want to just give a special acknowledgement to Laura Perryman, who I work for. She is a very well-known dry eye specialist in the States, and I wanted to thank her for allowing me to use a number of her images and slides in this presentation. So just to kind of go over briefly what we will be talking about today, we'll start kind of doing just a brief review of dry eye disease and meibomian gland dysfunction, as well as talking about the burden of disease, going over some of our current diagnostic tools and treatments, and then, giving kind of a background of intense pulse light, proposed mechanisms of action for it, an update on what is newest with IPL, and then going into how to implement it into your clinic. How do you choose good candidates? What is the actual procedure itself? And we'll finish up with a few cases. So starting out, most of you are students, so I'm sure that many of you are familiar with this definition put forth by the Tear Film and Ocular Surface Society Dry Eye Workshop 2. This is their definition of dry eye from that workshop back in 2017. And I just colored in a couple of the few key points here. So dry eye is a multifactorial disease of the ocular surface, and it's characterized by loss of homeostasis of that tear film, accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation, and neurosensory abnormalities play etiological roles. So I wanted to focus a little bit on evaporative eye and meibomian gland dysfunction. Historically, we would often differentiate dry eye into aqueous deficient and evaporative. But I think more and more doctors are starting to realize that really the majority of our dry eye patients have some kind of evaporative or meibomian gland disease, and you're almost always going to need to treat it in your patient. So I think a lot of us have stopped differentiating as much. And we know that meibomian gland, is one of the leading contributors to dry eye disease, and incidence is, thought to be as high as 70% of those patients. And we know this is a multifactorial problem that requires a multifactorial treatment. But the reason why I bring this up and this topic of facial rosacea next, to kind of understand why we're thinking about things like intense pulse light or light therapy for dry eye. And the reason for that, particularly in places like the States where I practice, there is a decent amount of people with the condition of facial rosacea. It's more common in Caucasian people, but about 10% of people we think have it. And of that population, about 80% have a concomitant meibomian gland dysfunction. And to note is that about 20% of cases in ocular signs, or we'll see ocular signs of meibomian gland dysfunction, will after precede the diagnosis of any skin rosacea. So this could be existing subclinically in a lot of our patients where they might not even realize they have rosacea until we start seeing the meibomian gland dysfunction. Also, just wanted to point out that IPL is actually regarded as a TFOS due to level 2 recommended treatment. IPL is a relatively newer treatment. I think a lot of doctors sort of don't even really think about it much when they're thinking about how to treat their patients because it's so new, or they may feel like, oh, it's, we don't really know enough about it. I don't know if I should recommend it to my patients or not. It was used off-label. It wasn't FDA approved for a long time in the States. And so I think some doctors are a little bit wary of it. But you can see here now that it's actually regarded by the Tear Film Ocular Surface Society as a level 2 treatment. After you've done the initial things like education, modification of environment and lifestyle and things like that, it's right there with things like prescription drops like cyclosporin, and, lubricants, overnight treatments, all of that. So that arrow points there. So did want to focus a little bit on, just a vicious circle of dry eye. So this is an idea put forth by Badwan. We call it the double vicious cycle of dry eye disease, where basically inflammation starts to beget inflammation. And once you get into the cycle, it sort of self-perpetuates itself. I think it's relatively widely understood that inflammation plays a key role in initiating and perpetuating dry eye. In the meibomian gland dysfunction, an inflammatory cycle is created, leading to the potential development of abnormal blood vessels known as telangiectasias. These abnormal blood vessels release pro-inflammatory mediators, around the eyes that further escalate inflammation. These abnormal blood vessels are bringing blood to the area that are bringing a lot of inflammatory factors. And then things like bacteria and Demodex mites flourish in that inflamed tissue that contribute to the clogging of the meibomian glands. So as those meibomian glands are clogged, the lipid layer of the tear film starts to fail. And then that leads to evaporation of the tears, and that increases. Then osmolarity increases, irritation and damage to the corneal surface ensues, and then the cycle just keeps perpetuating. So this is just another slide to kind of show the role of inflammation in dry eye and meibomian gland dysfunction. So normally, in a normal ocular response, you may have some kind of injury or insult, say a contact lens or LASIK surgery, allergies, something like that, and you'll have inflammation of some pro-inflammatory cytokines. Then you'll have amplification, T cell differentiation, in the lymph nodes. This is the afferent arm, which then will lead to recruitment and reactivation, the efferent arm, blood vessels, all of that. But then it will circle around and you'll eventually have resolution and immunoregulation. And so then you're out of the cycle, things return back to normal, the system works the way it's supposed to. What happens in dry eye, which is a dysregulated adaptive system, is we have that injury and insult, and we go through the amplification and recruitment, but instead of resolution, it just kind of circles back around to that initiation. So kind of like that previous slide, we're just going around and around. This slide shows in that cycle where our current treatments work. So these arrows here, the green one is your corticosteroid treatments. This maroon color is your cyclosporin, purple is your lifitegrast. So you can see, they all work on sort of different inflammatory factors, decreasing them, impacting them, different areas. And then I just wanted you to focus on the little blue stars here. This shows where intense pulse light treatment works in that system. And then GLA would be like your omega-3 fatty acids. So you can see that, they all work in different areas, and IPL actually targets quite a lot of them. So this is just kind of another slide. It shows basically the same thing. So, don't worry about remembering all the specific details or anything like that, but just another way to show that IPL is targeting a lot of different areas of that cycle. So dry eye, I think if you're a student or a doctor, you're probably well aware that many of our patients have dry eye. And I think it's something that we're starting to realize more is really a serious issue. It's not just your eyes are kind of dry and it bothers you for a short period of time. We see many very severe patients in our clinic, people where their eyes bother them so much that it impacts their productivity at work. It affects their ability to do the day-to-day things that they need to do. And we know that treating dry eye can take a lot of time. There's a lot of treatments that, take time for the patient to use. It can be very expensive to have all those doctor visits, to buy all those eye drops. And we know that it can really affect the quality of people's lives. We have many patients that have, depression related to their dry eye. Some people even have suicidal ideation because the symptoms they feel are so severe. And there's also the aesthetic issue. Patients don't want to have eyes that are all red, or eyelids that are all puffy and inflamed all the time. And then on doctors, it also takes a lot of chair time. Dry eye patients take longer than routine patients, just the education, the exam takes longer. It can be expensive on our end, the treatments, the diagnostic tools. It can affect things like our surgical outcomes. You may refer a patient for something like cataract surgery or LASIK, and they don't have as good of an outcome because that dry eye wasn't treated. And on society, at least in these are numbers for the states, there is a $55 billion societal cost and loss of productivity, as well as $3.8 billion cost to the U.S. healthcare system. If you look at the numbers on what third-party payers paid for dry eye. So this is a serious issue that costs real money, and it takes a lot of time and energy for many people. And the good thing is on the clinical side, we have quite a lot of good diagnostic tools now to help us diagnose dry eye. I would say most people are going to be able to do an external exam, slit lamp exam, hopefully have some kind of staining like fluorescein or lissamine green, and then you can do a tear break at time. So I'd say most people probably have access, hopefully, to these top 5 diagnostic tools. These more advanced ones, if you're doing a lot of dry eye in your clinic, you may have things like MMP9 and, Inflammadry, testing the inflammation, things like tear osmolarity or meibography to look at the meibomian glands. And then if you're really getting into it, you can get into things like interferometry and non-invasive tear breakup. Honestly, I haven't personally found these as useful, but certainly these top ones here. And then Schirmer's we use a lot in clinical trials, but honestly, in regular clinic, I don't find it to be that useful, but it is a tool that you can use. And the great thing is now is we also have a lot of treatment options. I graduated from optometry school in 2014, and we really just had like artificial tear steroids, and then Restasis had just come out. And that was basically it, and that was about 8 years ago. I feel, there's a few other treatments, but now we have so many, not just artificial tears and warm compresses, but a lot of good prescription medications and other in-office treatments. But when you look at this list overall, what do these treatments have in common? And really what they have in common is that almost all of them are at-home treatments that your patient has to remember to do. Really only a few of these, are something that you're going to be doing in office. Really, almost all of them are a burden your patient is going to have to deal with at home. And, so that's kind of one of the downsides of a lot of these common treatments. It's a high burden to patients. They have to be really good about remembering to use them every day, or their symptoms often come back. It can be a really expensive long-term cost of, say, having to be on Restasis for many, many decades or something like that. And there can be side effects, things like burning and stinging. And if you have a busy lifestyle, we have patients that are moms with little kids, remembering to take drops and stuff on top of everything you're doing can be quite difficult. And so that's where something like intense pulse light, which is an in-office procedure you can do in clinic, will hopefully decrease the amount of at-home treatments that your patients will need to do, and maybe take some of the burden of that off of them by having them just have to come into your clinic, certain periodic intervals and get their in-office treatment rather than having to do as much at home. So what is intense pulse light? So the background of it is it was initially a dermatological treatment, and it had been around for quite a while. Used for things like facial rosacea, port wine stains, hypertrichosis, so like hair removal, things like angiomas, telangiectasias. And about 20 years ago, ophthalmologist Toyos kind of just happened to notice that in his patients he was seeing in his eye clinic that had facial rosacea that was being treated by their dermatologist with intense pulse light, were actually showing improvement in their meibomian gland disease and dry eye disease. And not just in their subjective symptoms, but he actually found that their tear breakup time, the quality of their meibum, the appearance of their lid margin was actually better. And then they also seemed better positioned for meibomian gland expression as well. And that was just from having the IPL done on their face, not even near their eyes, where they were getting this benefit. So what intense pulse light is it's not a laser, it's a light. It's a non-laser high-intensity light source. It uses a flash lamp to produce non-coherent light outputs in wavelengths in the range 400 to 1200. Typically, we use between 5 to 600 nanometers. And it delivers controlled pulses of intense light for only a few milliseconds, which we then apply to the face and the eyelids. So there's different filters, and as light passes through those filters, only the desired wavelengths will go through. There is fluence, which is the optical energy that's delivered per unit area, usually ranges from 10 to 30. And we use divided pulses to, enhance safety and comfort on the patient. And so you can see here kind of the range there. And so you're like, okay, so we have this light, but how is this helping treat dry eye, And so there's a few proposed mechanisms. So that non-coherent light that we were talking about is absorbed by chromophores, so like melanin and hemoglobin, particularly oxyhemoglobin in the red blood cells. They absorb the light and it generates heat, which actually causes coagulation of the blood and thrombosis of those abnormal blood vessels. So the telangiectasias, those abnormal blood vessels are the ones that I mentioned before that are bringing a lot of inflammatory mediators to the eye. So if we can, basically thrombose all those small irregular blood vessels, then it decreases the inflammation coming to the eye. So it reduces that reservoir of inflammation. It interrupts that vicious cycle of inflammation we mentioned before. And it's those inflammatory mediators that come from those enamel vessels that can lead to the malfunction of meibomian glands. So that's why there's benefit to bleeding those vessels. Other things it does is photobiomodulation or photomodulation. This is basically something that's going on in our mitochondria. So if you remember back to your cell biology, the light energy in IPL is also absorbed by cytochrome C in our mitochondria, which is active in the electron transport chain. So what this does is actually improves ATP production, and that facilitates cellular functions like collagen synthesis and fibroblasts, motility of immune and regulatory cells. And, that's just sort of improving the whole system. IPL is also thought to control Demodex. These are mites that live on our eyelids that are known to contribute to dry eye. The IPL light is absorbed by chromophores in the exoskeleton of these mites, which kills them. They also are known to bring a bacterial load to the eyelid. So by killing them, you're reducing not just the impacts of the mite themselves, but also the bacteria that they're bringing as well. IPL also suppresses MMP9s, inflammatory factors, and modulates, in general, secretion of pro and anti-inflammatory molecules. So it's upregulating the anti-inflammatory ones and downregulating the pro-chemokines and cytokines. So this is just kind of a nice diagram of everything that I was talking about of the different areas that IPL treats. So the green arrows show where it is increasing the level of the target. So anti-inflammatory agents, collagen, elastin breakdown. And then the red shows where they decrease the level of the target. So things like the abnormal blood vessels, pro-inflammatory mediators, Demodex, etc. So another way to kind of think about the benefits is this model that Dr. Perryman came up with. She calls it the BESTOW model. This is a model that she uses for understanding meibomian gland dysfunction. And what's great about intense pulse light is actually hits 5 of the 6 of these elements. So we talked about with the bugs, it decreases bacteria and Demodex. The enzymes, those lipases and esterases, cytokines, and it's affecting that cytochrome C and improving cellular expression. It's known to impact inflammation and stasis of the meibum. We've actually seen improved morphology of the meibomian glands on confocal microscopy, as well as helping with obstruction and hyperkeratization of the eyelids, which could potentially decrease the pressure on the terminal ductules of the meibomian glands, which would improve expressibility. But the one thing that IPL does not actually seem to work on is the temperature. So while IPL has that light, it actually isn't bringing the temperature of the meibum hot enough to improve that expressibility. So what we actually find is we tend to recommend intense pulse light in combination with something like a thermal pulsation treatment to improve, to actually increase the temperature and expression of those glands. So these next 2 slides, again, just kind of get back to that idea of, is IPL, have that much information behind it? Because like I said, a lot of people think it's super new, they're not sure, but there's actually been quite a lot of scientific literature showing the scientific rationale for intense pulse light, showing that it's improved things like OSDI or ocular surface disease index scores, a common questionnaire that's used for dry eye. It improves meibomian gland secretion scores, corneal staining, tear breakup. So this is just one slide of a bunch of references. And then here's another one and another one and another one. So tons and tons of references. And one last one here. And I think we hope we will be able to make these slides available, or the video should be available if you want to look at those references. So, what are the benefits of IPL over other treatment options? So one is it has fast and effective improvement in signs and symptoms. It saves a lot of patient and doctor time. It improves compliance because, hopefully patients won't need to do as much at-home stuff. hopefully you won't have to write as many prescriptions. In the States, we have huge issues with something called prior authorizations that we have to write, trying to get coverage by our healthcare insurance companies for certain treatments that take a lot of time. So if you can decrease the amount you have to do, that is great. Hopefully access to care is maybe easier in the place that you're practicing. It also actually improves the general appearance of the skin and eyes often. And it allows for dry to become a procedure, which, if you like to do in-office procedures rather than just prescribing and send your patient home, it kind of gives you that option. So this is just a short list of some of the IPLs I'm most familiar with. There may be others around the world. I wouldn't be surprised if there are, but these are the ones I'm most familiar with. The first one is the M22 by Luminous. It also has a newer version of this that came out recently. This has been around the longest, and a lot of the research on IPL has been done on this system. And what's newest with this is they came out with the OptiLite, which is basically a smaller light guide, where before the light guides were all like relatively large, and it was fine for treating on the face, but it made getting around the eye very difficult. This smaller light guide just makes it easier to get around the eye. Another system that I've seen that is quite common in Canada is, actually, no, I'm sorry. There's the M22 as well as the iLight by Topcon. This is also commonly used in the States. This is a combination with low-level light therapy. And the kind of benefit of this one is you don't need any coupling gel, which you do with the M22, which I'll kind of show you later a little bit more details on. But I'm sorry, it's actually the EI that is commonly used in Canada. This is slightly different in that it uses something called intense regulated pulse light. So what this is it works on a slightly different mechanism of action where it uses neurological stimulation of the zygomatic nerve, which increases the parasympathetic outflow to the meibomian and lacrimal glands. And so basically each pulse is divided into subpulses, and those subpulses can have different light intensity and duration. A study by Wu back in 2020 that compared IPL to IRPL showed that both were effective. Both improved signs and symptoms of dry eye, but IPL was slightly more effective at improving meibomian gland secretion and lid margin scores and non-invasive breakup. But those differences may just be related to the density of flashes, the energy storage intermission between flashes, or the frequency of treatment. So certainly more research needs to be done, but there does seem to be, multiple options, and I would assume really more options will come out down the road as well. And kind of the newest updates for at least in the States are FDA approval of intense pulse light for meibomian gland dysfunction. We just got last year. So people are no longer doing it off label, which is great. I think a lot of times patients are wary of non-FDA approved treatments. So to have that is great. And then that OptiLite light guide I mentioned before. So you're thinking, okay, how am I going to start implementing this into my practice? So who are good candidates for intense pulse light? You're not necessarily going to recommend it to every single dry eye patient that you have. It's going to work particularly well for those people that have facial or ocular rosacea. You see those red blood vessels, on their skin. So people with telangiectasias, patients with high Demodex load, if you're seeing a lot of collarettes on their eyelids, if they're people that have just had poor success with a lot of treatments before, or difficulty with keeping up with those at-home treatments, or some patients that aren't interested in pharmaceuticals. I practice in Seattle. We have a lot of sort of like health-focused people here that don't want to take medications. They don't want to take a pill. They don't want stuff that's, could have a lot of other impacts systemically. And so kind of a targeted light treatment, they may consider to be safer or something they'd be more willing to do. And it also kind of has a nice benefit of improving other benign inflammatory skin lesions. So things like acne, It's been shown to improve chalazia and hordeola as well. But there are, of course, contraindications. I'd say the major one is amount of melanin in the skin, because the light is absorbed by melanin. The more darker pigmented that you are, the more at risk you are for things like hypopigmentation. So kind of the irony of me giving this talk on intense pulse light is I have actually never had intense pulse light done on myself, because on the Fitzpatrick scale, which I'll show a little bit later, I'm actually about a 5. And typically we treat people up to about a 4. Dr. Perryman has felt comfortable treating some people similar to my skin tone. If we try to do it when they're like most pale as we can in the summertime, and, adjusting the settings down. But you are going to want to be very careful with people with darker skin tone, as well as kind of related people with recent sun or tanning bed exposure, where they're going to have a lot of melanin that will absorb that light. Anyone with an active herpetic infection, because the light may stimulate that. Anyone with tattoos in the treatment area, things like eyeliner tattoo. You want to be careful with any systemic use of drugs that cause photosensitivity. Doxycycline is probably the most common one. I believe we typically recommend discontinuing it for about a week or 2. But Dr. Perryman has found that people on lower doses of it really aren't at as much at risk. So if people are on a low dose, she may just drop the settings of the IPL. But if you are on a pretty high dose, you just want to discontinue it. And then you'll want to be careful with wanted facial hair, because it will kill those hair follicles. So if you have patients that have beards or mustaches, you are not going to want to treat over those, because it'll be more difficult for that hair to grow back. So for the procedure itself, I work at the Perryman Eye Institute, so we do the Perryman protocol. The Toyos protocol is also a very commonly used one. Toyos is, the one that first started using IPL for dry eye. The Perryman protocol is sort of just like added on top of the Toyos protocol. So I'll kind of go over that. So first thing you're going to want to do is what we call the Fitzpatrick skin typing. So determining where someone's skin tone falls in this range. We use a questionnaire. We also ask questions about genetic heritage. Sometimes it can be a little bit hard to tell when you see people. So you want to ask, do they typically burn or do they tan, because of that risk of depigmentation and darker skin. We generally will do 4 treatments for most people, about 2 to 4 weeks apart. Ideally 3 weeks, and some people may need more treatments than that. And we also like to start with more conservative treatments. For first-time treatments or people that have had recent sun exposure, it's always best to start a little bit lower, and then see if you can move up. Then start too high and, have someone have a bad reaction. And then you may want to adjust, those subsequent treatments based upon patient's dermatological reaction. And generally, you don't actually have to do manual expression right after. Some doctors do after every treatment, but we actually kind of recommend waiting after a few IPLs, after the inflammation is more controlled, and then doing something like expression or thermal pulsation at that point. So this is that Fitzpatrick skin typing scale that I was talking about. So 1 through 4 can typically treat pretty easily with IPL, and then you'll want to be pretty careful with 5, and then we really don't recommend treating 6. And what you'll see is that it's that fluence, that level that you'll change depending on what their Fitzpatrick type is. And most of the IPLs have, it's pretty easy. You put in and it will adjust the settings. So it's relatively easy to do this. It makes it hard to make mistakes, which is good. So for our pre-procedure preparation for the treatment, we'll have the patient remove any face or eye makeup, usually some kind of makeup wipe, whatever method you prefer. If they have a bunch of eyelid makeup, just make sure that they really have removed it all. We recommend kind of keeping the hair pulled back, and we'll sometimes give patients a little stress ball to squeeze. And the reason for that is that the treatment, it feels kind of like a rubber band snap. Like it can be uncomfortable for some people. And so having something that they can squeeze can be helpful. We will instill a drop of topical anesthetic like proparacaine, as well as a non-preserved artificial tear. And then we do use laser grade corneal shields. So these are metal shields we actually insert under the eyelid, sort of where a contact lens would sit. And you don't have to do that. Some people use just stickers that they cover and they don't treat on the eyelid. It just sort of depends on your comfort level. We believe that treating the eyelid achieves better results, but you certainly can just do the face as well. So whatever you're comfortable with and whatever the laws and whatever place you're practicing allow for as well. After that, we apply a layer of ultrasound gel with sort of the edge of one of those wooden tongue depressors. And you do want to make sure that you don't get any of the gel into the eye. And then we do a couple test spots on the side of the face. And I do have a couple of videos I'll hopefully show later, and I'll let you know where to access them so you can actually watch the procedure on video. We like to do a couple of test spots just to gauge reaction, patient comfort, and make sure that the skin is reacting properly. And for step 1, we do the full face rosacea pass. So this is basically, you'll go over the entire face. Settings will depend on the patient. Then step 2 is the Toyo setting. So those are the ones from, ear, tragus to tragus, ear to ear, all the way across the nose. And you do want to make sure that when you're doing IPL, that you don't push. And the reason for that is when you push, that actually sort of constricts those telangiectasias, and it pushes out the blood cells and the hemoglobin. And so then when you're putting the light on, those cells aren't there to absorb the light, and then the blood vessels aren't actually ablated. So you don't want to push, you just want to rest it right on the skin, and then overlap each pulse by about 10%. And when you do a double passage, you go over it twice. Step 3 is then to treat the eyelids. We switch to the small light guide. And then you do want to make sure, and we actually go the upper lid, the lower lid. You want to avoid the eyelashes by about 2 millimeters and also do double pass. And then if your laws allow and you want to do it, you can also do sort of like an aesthetic cleanup if someone has some hyperpigmentation and someone wanted chin hairs or something they want to get rid of, you can then take care of those for them just sort of as a side bonus. Right. So once you've completed the procedure, you are going to want to remove the gel with the edge of the tongue depressor and then gauze to get any residual off. Wipe the skin with warm water, and then we do often recommend using sunscreen afterwards just to protect from skin exposure. And then sometimes we will also instill artificial tears and lumify onto the eye just if there's any redness. And for the following days after the procedure, we do recommend avoiding sun exposure. So using sunscreen if you're outside, and then avoiding things like exercise and hot tubs, excess alcohol or caffeine, basically things that are going to cause your blood vessels to dilate. We want to avoid those, for at least the next few days. And there are, of course, some potential side effects to intense pulse light. There's no treatment without some. The most common is reddening or pinking of the skins, kind of to be expected. Some people will also have some potential mild edema, hyperpigmentation and burning, stinging, even some mild blistering. These are all relatively mild for most people and will usually resolve within a week, other than hair loss, which is generally pretty long term. So again, be careful with any wanted hair. Lastly, we'll finish up with a few cases from our clinic. So this one is a very typical facial rosacea patient. So this is a 39-year-old male. He had severe rosacea, keratoconjunctivitis, and floppy eyelid syndrome. So you can see these were his meibomian glands and his eyelids everted back in October 2020. And he actually had a decreased best corrected VA. His vision was slightly decreased. He had a new diagnosis of obstructive sleep apnea as well and alcohol dependency. After 6 IPL treatments, his vision actually improved. You know, the surface of his cornea and everything has actually improved so much that his vision was improved. His symptoms actually improved enough that he was able to return to work. His meibography normalized. So you can see these photos taken in April 2021. So, you know, only like 6 months later, all this inflammation and everything is significantly improved. Like you can really see the details of the meibomian gland so much better. And his meibomian gland expressibility was normalized as well. Second case is prostaglandin-induced ocular surface disease. So, you know, we have many patients that have glaucoma. They're on prostaglandin analog treatments for their glaucoma that are very effective glaucoma treatments. The downside is we do know that they can also contribute to ocular surface disease. And the issue is you really don't want to discontinue them off, you know, their glaucoma treatments, particularly if they're effective. So we need a way to treat their associated dry eye without discontinuing the pharmaceutical drops that they're on. So this treatment before, you can really see a lot of redness, irritation. It was a 70-year-old male with glaucoma that had been on prostaglandins for over a decade. He had dry eye, secondary meibomian gland dysfunction, and he was very symptomatic. And for him, after just 3 treatments, you can see, you know, the eye is quite a bit wider, just a lot more comfortable. He's quite a bit less symptomatic, and that was after 3 treatments. This third case is kind of an interesting one. This is for a condition called dupilumab-induced ocular surface disease, or DIOSD. And this is a condition I think that many of us are going to start to see more in clinic. It's related to a biologic for eczema called dupilumab, or Dupixent. And it's used for eczema as well as other atopic conditions. And it came out back in 2017. And it's a very effective treatment for eczema. This is why a lot of patients are put on it. It basically blocks IL-4 and IL-13. And of the patients that are put on it, about 30 to even some reports say 70% of patients experience a conjunctivitis. So basically ocular side effects post starting the medication that include epiphora, blepharitis, conjunctivitis, keratitis, meibomian gland dysfunction. So this constellation of symptoms that we now call dupilumab-induced ocular surface disease, which generally will treat with steroids and immunomodulators. But the issue with it blocking IL-4 and IL-13 is IL-13 is actually important for maintaining goblet cell density. So if we're impacting our goblet cells, of course, that's going to impact our dry eye and this, you know, the sort of integrity of the ocular surface. So we had a patient who was a 35-year-old female who had a, you know, rosacea for many years and then eczema, atopic dermatitis, that presented to our clinic also in October of 2020. She was having severe blepharitis, epiphora, and keratitis after starting dupilumab. So these were some of her initial photos. Like you can just see all the edema. The eye was really red and just angry and unhappy. This was another before photo. So you can really see the redness here. And post IPL treatment, this is actually just 30 minutes after one treatment. She had dramatic improvements in her lid edema, her epiphora, that conjunctival injection, and keratitis after just 2 treatments. And we did do this in combination with topical lifitegrast and loteprednol. One of her issues is she is a new mom. And so it was really hard for her to keep up with her at-home treatment. She just couldn't, so she was too busy with other stuff. So she was actually supposed to return for IPL, but just, never made it back for quite a few months. And then back in March 2021, so, about 5 months later, she had a severe recurrence because she just couldn't keep up with the steroids and the lifitegrast. So we did 3 more treatments in clinic, and significantly improved, where she said, I have my life back. My eyes aren't so red and angry all the time. And you can see these before and after treatments from October 2021 to October 2020 to April 2021, just significant improvement in the appearance and comfort of the patient. So this is a case that actually we wrote up for Academy of Optometry last year and published earlier this year in the Journal of Dry Eye Disease as well, if you want to read about it. And then our last case is actually for chalazia. So this is actually currently in clinical trial, seeing if IPL will be an effective non-pharmaceutical, non-surgical treatment for chalazia and hordeola. So these are a couple examples of a patient here that had acute chalazia with a lot of lid edema. This is immediately after the IPL. You can see that decrease in edema, pretty substantial decrease just directly after the treatment. And then 20 hours later, also improving. This was an acute chalazia that, also, just 3 days later, it's almost completely gone. In 5 days, you can't even tell it was there, which was a great improvement. And this is treating directly on the eyelid, on the area where the chalazia is. And then just one more photo here of a before and after showing improvement. So that clinical trial is still ongoing, but I wouldn't be surprised if down the road we start to implement IPL as, kind of a standard treatment for these lid lesions on top of, the other surgical treatments that we recommend now. So what's next for intense pulse light? One is potentially, like I mentioned before, some careful treatment of some darker skin tones. We actually will hope we test this out at some point on me. We haven't quite done it, maybe in the winter when I haven't been out. I was just out in the sun earlier today, maybe a time when I'm not doing that. Like I just mentioned, some non-surgical treatment for chalazia. And then as well as combination treatment with some other newer modalities, things like low-level light therapy and radio frequency as well. So, it's kind of an exciting time for dry eye. There's a lot of different treatments available, and on the horizon. So, IPL will hopefully be, one that you can start to think about implementing. So in conclusion, intense pulse light's been shown to be an effective treatment with a lot of good scientific rationale behind it for meibomian gland dysfunction and dry eye disease. It has multiple mechanisms of action and is basically just an excellent addition to our current toolkit of treatments. It's anti-inflammatory, effects last a good amount of time, and it's an in-office procedure. So it eliminates the burden of adherence to at-home treatments. It can be kind of fun to do if you're into doing procedures, and it has those kind of nice aesthetic side benefits. So, even if you're not necessarily ready to put this in your own clinic, I hope you were able to learn at least a little bit about, how it works, what patients it might work for. So if you have doctors in your area that might have this, you may know which patients make sense to refer and to know that this is a good, legitimate treatment option for those patients. So just my references here. And then my contact information, certainly you can send me emails at my email or follow me on Instagram at Dr. Maiti's Eyeballs and stuff. I always like to connect with other optometrists and doctors about, I love to talk about eye stuff. So certainly feel free to connect with me. And if you want to learn more about our clinic, which this is actually a photo of our clinic from the outside, look us up on dryeyemaster.com. Yeah, that's it. Thank you so much.
Awesome. Great. Thank you so much, Dr. Maiti, for taking us through the entire. I think you covered everything about IPL from the scratch, what it is and how to go about it. I think it's really important for us to understand. I do also understand that a couple of us who are attending, it's very new for us in this part of the world. And
Yes.
while we were planning up the session, and you did also mention at the end that it's always good to know uh, which patients are suitable, and if we can find out some doctors doing across to refer our patients, as it is already as a part of level 2 of dry eye management according to TFOS, right? So thank you so
Exactly.
much for taking us through the entire IPL system. I just had one brief question to ask is, usually how many sittings or how many sessions are needed for it? Does it depend on the case, or is there a minimum amount which everybody has to go through? Any thoughts on that?
Yeah, it certainly depends. It varies from patient to patient. So we generally start out with at least 4 treatments for most people, spaced about 3 weeks apart if we can. And for some people may not need as many if they're doing well after 3 treatments. But I'd say it's probably more common that people down the road may need more treatments. It may not be 3 weeks after their 4th one, but we will have people, particularly if they're having a flare up or something, like a few months down the road, come back for like a touch up treatment. So it does vary. I'd say 4 to 6 is very typical.
Okay, right. So the whole treatment probably can last for about a year or so if we consider every 3 months follow up and all that, right?
Right. Yeah. And yeah, again, it just kind of depends on, how the patient, and if they're on, if they're on other treatments or not as well. Often patients will be also on, some kind of pharmacological drop, or steroid, or doing lid hygiene and stuff like that too. So, with dry eye, there's so many different factors that can affect it. It's just going to vary from patient to patient.
Right. And just a connecting question. So when we are doing IPL for patients, the other treatment what the patient was still on for dry eye management still continues at the same rate, or you kind of tone down that, or any modifications do you do for the remaining treatment?
Yeah. I mean, oftentimes our goal is to hopefully decrease their need to be on those other treatments. So, a lot of the time we will do things concurrently. Like we'll have patients, we'll start them on a steroid or cyclosporin or lifitegrast or like sort of at the same time that we're doing intense pulse light. And then for many people, we kind of start to see like, hey, why don't you stop your cyclosporin or lifitegrast, and we'll see how you're doing with just the intense pulse light. So, it's always kind of our goal to get people to sort of as minimal treatment as they need. But it's not uncommon for people to be using multiple things at the same time.
Right. Yeah. The only concern is sometimes the patients, we have to be a good counselor and advise them, because they'll say, I'm already doing this and I have to add on another thing. And, in terms of finances, in terms of visits and all of that, it's really something which we have to be careful in terms of explaining to patients.
Right.
There's one question which has popped up. It is about performing IPL therapy in patients with any facial issues like tumors or palsy. Is there any contraindication on those lines?
Not really, as long as it's not like a pigmented tumor. So if it's something like a melanoma, right, you're not going to want, hopefully you'll have referred them to dermatology to get that taken care of. But yeah, things like palsy really shouldn't be an issue. We haven't really come up with anything like that as a problem in our clinic, and even some people, if they can't handle the corneal shields or something like that, we will just use the stickers on top and then not treat around their eye. So you can often modify things as well. Even we'll just have some patients that are so nervous about the procedure that we will do things like prescribe them Xanax or something to like calm them down if we need to do that before the treatment. So you can, kind of do things like that. But yeah, it really shouldn't be an issue.
Right. So would it be advisable for us to work together with dermatology for IPL treatments, or is just that overall view when we see something happening, it's good to refer, right?
Exactly. Yeah. I mean, I don't think you necessarily would always need to consult with dermatology, but it's always good to work with colleagues. So yeah, if you see a lesion on the skin that you're kind of like suspicious about, certainly. And then, if there's any side effects that you're concerned about, dermatology should be quite familiar with intense pulse light because they use it for many treatments. So they're also a good general resource for information about it as well.
Right. And is there any upper limit in terms of, repeating the sessions? How many should be the maximum? Is there such data in experience? And at what signs and symptoms would you ideally stop doing the sessions? Is there any particular thing which you are looking at? If this happens, I must stop.
Yeah, there really isn't any upper limit on repetition. So, some people just like to come back and get the treatments. Like, they like the effect, they feel better, they like the way it makes their skin look. So, you could have a patient that wanted to come back to see you like every month, and that would be totally fine. There's really no long-term downside to that. For signs and symptoms of like why you would want to stop like mid-session, I'd say the most common reason why we have to do that is because patients just can't tolerate it. Some people are just very sensitive to the way that it feels, that it's a rubber band snap, and I'd say the majority of patients after the first few, they sort of desensitize to it and they can handle it, just like, other treatments maybe you've done, but some people just can't. And they'll say, hey, I thought I could handle this and I can't. And then you'll just stop and discontinue. But it's usually something like that more than, some kind of like bad result that you're seeing. For some people, you may also just say you do the treatment and you get too much reddening of the skin or a blistering or something. Then you may just want to adjust your settings rather than discontinue. So decreasing the fluence or whatever. So usually you won't necessarily have to stop completely unless the patient just says that they want you to.
That's right. So I think it's more of a combination treatment as well, where your patient goes back, observes, and when they come back, they tell you, I had this experience after 10 hours, after 2 days of IPL, and then you adjust your treatment module. As you said, you adjust the settings, you go a bit lower, or you try to do some different things rather than troubling the patient again. Right. Wonderful. So I think we have come to an end. We have taken most of the questions. And as Dr. Maiti said earlier, if you have any questions, I think first you should go and visit Dry Eye Master. I think there are a lot of short videos. I have watched it, so I can vouch for it as well. There are a lot of short videos explaining step-by-step procedures. So if you want to learn more about that with demonstrations, I think that's a good YouTube channel to visit. And if anything else, you can always contact Dr. Maiti onto her social media and email, and either of us at OOLS would also be happy to connect you as well.
Yes. Yeah, and there's just one last recommendation. If you are on Facebook, there's actually a Facebook group called OS Docs, OSDOCS. It's like ocular surface disease doctors. There's a lot of doctors there that do treatments like intense pulse light and dry eye treatments. If you want to ask doctors questions about like what they're doing in clinic, things they've done, that is a great resource. Lots of awesome people willing to share their information, a really collegiate group. So OS Docs is also a good resource.
Right, with good case examples and live cases with pictures. So it's wonderful. Yeah, thanks for bringing that up. We do have session planned over a couple of weekends. Thank you everyone for attending. Thank you, Dr. Maiti, for spending your Saturday evening with us. Take care and be safe and have a good evening ahead. Bye-bye.
Thank you. Good night or good morning.
Bye. Take care.
Bye.